our second Gecko session of 2022, which will be devoted to a new topic that we've introduced, and that is that of radiology. So Gecko radiology. As you all know, the Gecko sessions are hosted by the Gastro Foundation together with Project ECHO at the University of New Mexico. And these sessions are held every Wednesday at 4:30. We have 67 registrations today from 17 countries. And as you all know, the chat session is open and you're very welcome to post your questions there. We're focusing on radiology this year really because we are very committed to introducing and teaching POCUS, which is point of care ultrasound training. This will be a series of lectures which will be conducted later in the year and which we will encourage you to attend because it's something that we feel will be very beneficial to clinicians, not only in South Africa, but in sub-Saharan Africa. Our chair today is Ernst Boshoff, who's a radiologist at the Donald Gordon Hospital. He presents many of our IBD cases, the radiology of our IBD cases at our journal club, and I've enjoyed them very much. And Ernst, it's a great pleasure to see you here and join our team. And then Sally Candy, our speaker, who gave a masterclass in radiology last year at our postgraduate fellows program that we have yearly, our SPEAR postgraduate fellows program. It really was excellent, and we really felt that she would be a very good person to inaugurate this new specialty. I might add, Ernst, if you don't mind me saying, I know you're going to introduce Sally, but Sally's actually more famous as a gastroenterologist. She is the first author on a paper which looked at azathioprine in a double placebo-controlled trial in Crohn's disease together with John Wright. It was published in Gut in 1995, and for many years we would roam the world at all the conferences and it would be Candy and Wright, Candy and Wright, Candy and Wright. So here she is, famous as a gastroenterologist, but this afternoon going to present radiology. So over to you, Ernst.
Unmute yourself.
Thank you, Chris. Welcome everybody. Yeah, I know Professor Candy more as a neuroradiologist, but I think she is a jack of all trades and also a master of gastroenterology radiology. She has several publications. She's a professor at UCT, and I think we're going to let her do the presentation and take questions at the end. If you guys can post any specific questions to the chat group, we'll make notes and we'll choose the best ones. And we will then discuss some of the slides. Over to you, Sally.
Thank you. Am I able to share my screen now, Cheryl? Yes, you can. Let's see if I can. How's that? Are we on?
All good, you can carry on.
Okay, good. So thank you very much for the, how's the volume?
Just stay a little bit closer to your screen. Yeah.
Better?
Much better, thanks.
This is not quite like standing up in front of an audience, I have to say that, but I guess we're just in a changing world. And so welcome to everyone. Yes, as my introducers have said, I in a previous life was a gastroenterologist of sorts, and then moved into radiology because it all seemed to be about radiology. And you know, as much as we thought we could get the answers from taking histories and doing examinations, finally it was all about the imaging. So I'm hoping to be able to share a little bit of insight that I've acquired over the years into very basic radiology imaging. There's no fancy stuff here. We'll talk a little bit at the end about MRI, but basically it's all about the plain film. So the humble X-ray. So many years ago, before the Rinderpest, before cell phones and PlayStations and things that keep us occupied and distracted these days. We used to go in South Africa, I believe we've got an international audience, we used to go to what we call the bioscope. And before the main feature, which was the real film, we would always have a cartoon. And the cartoon that I was very fond of was called Wile E. Coyote. And some of you may remember this. It was a story of two animals. It was a coyote and a roadrunner, who was a bird who was much cleverer than the coyote. And so the coyote, although he thought he was very clever, would always end up getting either squashed by a rock or at the bottom of some sort of valley. He always ended up being flattened. And this is a picture of Wile E. Coyote that's been stapled onto a vehicle. And this is how I think of play and film. I think of play and film as being just, you can't quite get into it. You can't quite see it. It's not 3D. It's a representation of the body. And so it requires a lot more thought and insight than does cross-sectional imaging that we now have access to. So our registrars are brilliant at CT scanning. You give them a CT scan and they can tell you everything about it. But play and film is much more mysterious. So I'm hoping just to very briefly introduce play and film in abdominal imaging and the kinds of things that we should be looking for and should not be missing. So broadly speaking, we're looking for stuff in the wrong place. We're looking for air in the wrong place, calcium in the wrong place, fats always seems to be in the wrong place, and then things like other undesirables, masses, lines that have gone wandering in the wrong places, intruders of various sorts. And very often we're looking for pus. Pus is never a good thing. It's never in the right place. So air in the wrong place. It can be very easy, and you don't have to be a radiologist. You don't even have to be a postman to make this diagnosis. There's air underneath these diaphragms, and clearly there's been either you guys have been in there operating or something has perforated. When it's this easy, nobody has a problem. It isn't, however, always this easy. And when it comes to babies' abdomens, it can be extremely difficult. They're very small, they wriggle, they have lines everywhere if they've been born with difficulty. If they're in the ICU, there's a lot of distraction, and it's very, very difficult to interpret what's going on in the pediatric, particularly in the neonatal abdomen. So sometimes it does help to call a friend, and so let's have a look at this. Can I just ask a question? Is there a sidebar that's obscuring the details of the screen?
No,
it's quite no.
No.
You've got yeah, okay. So in this abdomen, what we're seeing is is evidence of free air. And this is a critical thing to look for in the pediatric abdomen. Children complain a lot, but they don't specifically complain about abdominal pain. So perforations occur particularly in premature infants very rapidly, very easily, and we end up with air in the intra-abdominal space, which can be quite difficult to see. Also, the point about the pediatric X-ray is that it's always done in the supine position. So the baby's lying on its back and air is going to rise up to the top. It's not going to rise up underneath the diaphragms in a convenient fashion as it does in adults who are standing in the erect X-ray. So what we are looking for is evidence of air. And there are many different names that have been given to the different signs that we look for. So in this particular example, what we're seeing here is a large, well-defined lucency, which is overlying really the entire intra-abdominal cavity. And we can kind of see the liver through it, but it's quite hard to see that. We're not seeing any dilated loops of bowel here, which would have given us the clue that there was perhaps an obstruction prior to the perforation, but that's not important. This is called the football sign. But more discreetly, and this is what I want to bring your attention to, is this curvy linear density that we're seeing here. Very easy to overlook, very easy to confuse with a dilated loop bowel. In fact, this is the falciform ligament attached to the liver, and what we're seeing is air on either side. And so as with all X-rays, as with all X-rays, we can only see things if there is a difference in the density between two adjacent items. So here we're talking about the density of the falciform ligament and the air around it. So a lot of names have been given to these, to free air. Here's another example of it here. A little less obvious than on the last one. In this one, what we're seeing is outlining out of the bowel, air in the bowel, with air outside the bowel. And this is known as Wriggler's sign. So here you can see that there is bowel dilatation, but the important thing is not that the patient is obstructed, is that the patient has actually perforated, which takes them from a pretty dangerous situation into a critical situation. So it's very important to be able to pick up the presence of free air. By the by, somebody managed to break this poor kidney's femur in the process of the, tibia in the process of the delivery, I'm presuming. So while we're looking at the abdominal film, we're also looking for all the extraneous other things that are on the film. So we're looking at the bones, we're looking at the soft tissues. We need all the information we can get. All right, so as we said, it's easy in theory, but the moment we go onto a supine film, things get a bit more difficult. And so there are a lot of different names that have been given to the different signs that we see when there is free air. And so this X-ray here, which is rather difficult to appreciate, but I think what you can see is that there's a very well-defined and rather deep sulcus sign here. And over here, there's definitely a little bit of air, which seems to be positioning itself somewhere around the diaphragm. And this has been referred to as the leaping dolphin sign. And maybe with the eye of faith, you can see that there are two little wedges here. I think this image is probably very small on your screens, but that's the double dolphin sign that's described on the supine film. This is the Doge of Venice, and he wears a particular kind of hat, which is called a Doge's hat, or a cupola. This was a nice little image that I found of the Snoop Doge of Venice that will amuse our younger audience. And just so that you know that what we're actually looking for is a cupola is a particular shaped dome, which takes the air takes the form of this when we're looking at a supine film. So where else do we find air? So this is often subtle, but if you know what you're looking for, you'll find it. And I think it's quite clear to see here that there is free air in a branching system, which is communicating with a more tubular, larger structure, which is obviously the main bile duct. And you gastroenterologists, you know this, but it's very important to try and distinguish the difference between this, which is not a great situation, but it's not critical, from this one, which, although it's a lousy small image, shows you a much more lattice-like pattern to the air, which is going right out to the periphery of the liver, and is not in the biliary system, but in the portal system. And I think probably you can see here that there's abnormality in the bowel loops, with evidence of these little sort of almost fecal-like bubbles of gas. And what's the difference between these two images is that this patient on the left has air in the biliary system, which could be related to a previous cholecystectomy or a stent. It's not necessarily that pathological, as opposed to this baby who has very significant sepsis in the abdomen and has developed portal empyema, and air is in the actual portal tracts. And just so in case we have non-believers in the room, I have shown a CT scan to demonstrate biliary air. The black stuff on a CT scan is either air or fat. Let you into that little secret. In this instance, it's clearly air. And on the one on the right-hand side, notice how far out the air goes, right out to the periphery. So this is not in the biliary system. This is in fact in the portal system. Very dangerous situation. More danger. Here we've got an abdominal X-ray of a patient who presented with a fairly acute abdominal pain, particularly localizing to the right upper quadrant. We notice immediately that there's a large dilated loop of central bowel. Very hard to know exactly where that is, but probably more important, and the reason that the patient is presenting, is this crescentic lucency that we're seeing here, right around where we expect the gallbladder to be. A dilated gallbladder with air in the wall, and this is a gangrenous gallbladder, which we're seeing here beautifully on the CT scan. Again, it takes all the mystery out of it. It's black, it's air, and it's in the wrong place. So unless one's thought about it, very easy to overlook. The question we always get asked is the patient obstructed? Everybody comes in with abdominal pain to the casualty, and the question we get asked is the patient obstructed? And there are a couple of things which can actually mimic obstruction. Obstruction is very difficult to see because not everybody has large dilated loops of bowel. That makes life a lot easier. This one was a case in point. Is the patient obstructed? And what I bring your attention to here is this dilated loop of bowel that looks for all the world as though there's free air beneath the diaphragm. There's a nice thin diaphragm here, equally over on that side. But what this is a condition which is called chylodete. And this is a mimic of air under the diaphragm or bowel distension. What it is, in fact, is just a loop of bowel which has interposed itself in front of the liver and is a mimicker of obstruction. So just to be aware of that. Is it small bowel or is it large bowel? Very difficult in children, particularly. We don't even bother to try and decide whether it's small or large bowel. Is the bowel dilated? Yes, it is. If it's central, it kind of makes us think it's more likely to be small bowel, but in children, it's really hard to distinguish between small bowel and large bowel. They don't have the typical appearance that adults have. And so in an adult, what we're looking for in small bowel are these beautiful folds that we used to see on small bowel enteroclysis. Thank goodness those days have gone. As I said when I addressed the registrars before, many of you probably did not grow up in the era of small bowel enteroclysis or small bowel enemas, as we used to call them. Absolute nightmare for both patient and radiologist. Getting that tube down into the jejunum is not for the faint-hearted. You definitely have to use the Valium on yourself rather than on the patient. And it's what you're trying to do is to get a tube far enough down to actually pump contrast, thin diluted contrast into the small bowel so that you can see the detail of the small bowel wall. And you certainly do. And this is what you see. You see these valvulae conventes. This cannot be large bowel. This is what small bowel loops look like. And they have a particular pattern in the duodenum, in the jejunum, and the ileum, which we used to be very familiar with. The large bowel, on the other hand, has what's called Hallstrations. These do not run across the entire lumen. They actually stop halfway. This is obviously a completely classic coffee bean volvulus, which the postman can make the diagnosis of this. But the important thing here is what we're seeing are these large bowel Hallstrations. And this point here where the two walls of these incredibly dilated loops of large bowel have summed together to create what is effectively a double wall or a summation line. And that's a very classic presentation of the sigmoid volvulus. But fortunately for us, they don't often read the textbooks and they don't look classic. So one has to sort of allow for a certain amount of variation. Here's another example. Is this bowel obstruction? Well, in this case, we have uniform distension of both small and large bowel. We can see the Hallstrations of the large bowel here very clearly. Sorry, my mouse is not responding at all. So we've got large bowel here. We've probably got loops of small bowel posteriorly here. We can see that there are lines in this patient. This patient has recently had surgery. And in fact, this is a case of an ileus, there's no transition point. We're not seeing disproportionate dilatation of any part of the bowel. And that helps us to decide whether this is truly a mechanical obstruction versus an ileus. Because it's, as I said before, everyone wants to know whether there's bowel obstruction or not. And you do not want to take a patient to theatre who doesn't have an obstruction. So just to be aware of it. And, you know, as radiologists, we ask for as much clinical information as you can give us. It makes our lives a lot easier. Not all air, when organs rupture, not all air presents itself in the abdominal cavity. It can occur in the retroperitoneum, and that's a lot more challenging. So what do we look out for? We look out for those retroperitoneal structures and outlined by air. And here's a classic one of the psoas muscle. There's the kidney. There's that black line. What we're seeing here is retroperitoneal air. How do we know? How do we know it's not just very prominent fat? Well, we do the decubitus view, and that air does not move when it's in the retroperitoneum. So that's the clue that it's retroperitoneal free air. All right, so done with air for the time being. What about the lines? So more and more babies particularly are receiving venous catheters and arterial catheters. And it's terribly important for us as radiologists, but for you as clinicians, because in the middle of the night when radiologists are in their beds, because we know that radiologists don't work at night, when you're having to actually read the plain film, it's terribly important that you know whether the line is in the right place. You've placed it, and now you want to know whether it's in the right place. So the first line that we're going to look at is the umbilical venous line, and we all know where we're supposed to put it, and it should go into the umbilical vein, obviously, into the inferior vena cava at the level of the diaphragm. So it's going through that portal vein and into the vena cava. So it should be sitting up here. It should not be lower than that. And ideally, it shouldn't be any higher than that. Let's just go back to that one again. So just to recap, that's where it's going to be. Very hard to say whether it's on the right or the left. So if the patient is rotated, it's very hard often to tell whether you're actually looking at an arterial position or a venous position. But that's classically where it should be. What about the umbilical artery line? So in this instance, we're passing the catheter through the umbilical artery. It's going into the internal iliac artery, up into the common iliac, up into the aorta, and we want it to be positioned above the celiac axis. We do not want it to be going off into any of the branches of the aorta. So the ideal position for the catheter tip in an umbilical artery is positioned about here, somewhere between about T6 and T10. Count the ribs, easy to do. All right, moving on to other stuff in the wrong place. Calcification. It can be easy, it can be very difficult. So in this patient, I think this is probably a very simple one to pick up, that we have a well-defined rounded density in a place where the appendix is roughly positioned. And so this is a fairly simple one. It's not necessarily the case that this is appendicitis, but when you see a calcification in a patient who has abdominal pain in that position, it's a very strong indicator to there being acute appendicitis. Obviously, in these days, you're going to go on and you're going to do ultrasound, compression ultrasound, and probably in some cases end up with a CT scan. But in the old days, when we only had plain film, this was often all we had to go on. So you're looking for evidence of localized ileus or obstruction in the small bowel adjacent to a calcification. Also, just by the by, notice what's happening with the bladder. The bladder is one of those underappreciated organs on plain film. The patient will be sitting with the bladder up to their trachea, and for some reason hasn't complained, and it gets missed every time. people don't notice the bladder. You can see it when it's full. So what about other bits of calcium? So gallstones can be very obvious, or they can be not obvious at all. And in this case, if one's looking for them, they're very obvious. They look like a little bunch of grapes. But quite often they're not radio opaque, and you don't see them on even on CT scan, depending on their calcium content. You may or may not be visible. So ultrasound really is your friend in this instance. You will see stones on ultrasound always if you look for them. So the absence on a plain film does not exclude the diagnosis of gallstones. And the presence on plain film does not mean that the patient's got cholecystitis. So it's all to do with the clinical presentation. Here's a lovely sort of Old Testament film. We don't see this very often, but this is calcium which has been deposited in the wall of the gallbladder, and there's nothing else that looks like this. This is the porcelain gallbladder. It used to be described as being a precancerous condition. It probably isn't quite as bad as we used to think it is, but if you see it, it's definitely something that should be noted, even if it's asymptomatic. This is often more discreet and difficult to see, but when you see it, it's extremely helpful. This sort of punctate, amorphous, almost sponge-like calcification running transversely across the abdomen at about this level. So somewhere in the T12, L1 sort of region in the vicinity of the pancreas. And it's a very, very good indicator of chronic pancreatitis. And you often have to look no further for the cause of the abdominal pain when you see a picture like that. We have a lot of this in South Africa, and I'm sure that in several other parts of the world where there's a lot of sheep. This is the Echinococcus tapeworm, which produces the hydatid cyst. And when they collapse, all the internal membranes collapse and may calcify, and this can be a very pathognomonic of the condition. Not much else is going to look like that on a plain film, but of course not all hydatids calcify. All right, so what about other things in the abdomen? So we get asked to look for a lot of strange requests come through radiology, should we say. This was a 29-year-old patient who presented with some left iliac fossa pain. She couldn't remember whether she had an IUCD in or not. And on examination, there were no strings to be felt at the IUCD, but on a rectal examination, which was done, which is a good thing, the doctor who did the examination felt that they felt metal in the rectum. And so the idea was that possibly an IUCD had migrated into the rectum, and we were asked to do plain film to look for the presence or absence of this. As it turns out, she had fallopian clips, so it would have been a little bit of a sort of a overkill if she had had an IUCD in addition. So we weren't able to see an IUCD, but what we did notice was that in her rectum, there was this very dense sort of punctate calcium. And as we started looking through the large bowel, you could see that there was a bit of fecal loading, but there was I'm not sure if it's showing up very well, but there were these very fine flecks of calcium, of increased density in her large bowel. And so while we were talking to her, I said to her, "Do you eat sand?" And she said, "Yes, but only in Tanzania." So we referred her back to her physician and suggested that possibly what had started off as sand had ended up as cement, and that was probably what they were feeling in her rectum. She certainly did not have an IUCD out of place. However, IUCDs do have a habit, and the gynecologists tell me that actually it's not uncommon for IUCDs to go wandering. And so Plain film can be very helpful. They certainly virtually all IUCDs are radiopaque. So if they're in place, you will see them. But the trouble is that in this position, you can't say exactly where that is. And so is that in the uterus or is it not in the uterus? And this is a very easy thing to resolve by just popping the patient onto the CT scanner and doing a limited study, ensuring, of course, first that they're not pregnant, but doing a limited study to establish exactly where where the IUCD is. And here we can see, we don't see a lot of detail of the uterus on CT scan. As you can see, it looks a bit of a blur, but this is clearly outside the uterine cavity and probably half embedded in the wall as it was on its way out. So CT scanning often saves the day, but certainly in addition to plain film. So let's talk about the role of CT scanning, because obviously everyone these days is using CT scanning. I mean, there are hospitals in South Africa where there's a CT scanner where there's virtually no doctor at all. So it's very useful to be able to interpret CT scans. So what is it, how does it improve on the old-fashioned enteroclysis that we used to do in the old days? So it's very good for looking at the mesentery, at the perienteric fat, at the solid organs, at any fistulae or abscesses are easy to see. We give intravenous contrast so we can see enhancement of the bowel. We can look for prominent vasorecta in the mesentery. We can see nodes and we can see inflammatory change. The problem with CT enteroclysis is that, like small bowel enemas, you have to get the tube into the right place. If you don't get it into the right place, if you just ask the patient to drink some radiopaque liquid, you're not going to get adequate distension. And so this renders the study suboptimal, and it isn't as it used to be in the old days, where we would just pump that contrast down there until the bowel was fully dilated and there would be no question as to whether there was or wasn't a mucosal abnormality or a small area of obstruction. So if you don't dilate the bowel up, you're going to end up with little transient areas which can look for all the world like mural abnormalities or obstructions. Just a little bit of introduction as to how we do it. We put this large tube down under fluoroscopic guidance, so there's still radiation involved in this procedure, and it isn't any easier than doing a small bowel enteroclysis, that aspect of it. And we can use either positive oral contrast, which means we use iodine or even barium to dilute barium, or we can use water. And in addition, we can add intravenous contrast, which allows us to look at mural enhancement of the bowel, which adds to the whole dynamic. But there is significant radiation, and one should not forget that, because it's so easily accessible that we tend to forget that the radiation dose can be quite high. On modern scanners, it's been significantly reduced. As it's now about 5 milligrays as opposed to the 25 that it used to be in the old days with the old scanners. So we're not as concerned about radiation as we used to be. So where does CT enterography become very useful? Well, as everybody knows, in Cape Town, Crohn's disease was a subject very close to my heart, and CT enterography really has revolutionized our appreciation of the different changes that you find. So what are we looking at here? Well, first of all, once again, the two arrows that we're seeing here is we're seeing mural enhancement. So we've given intravenous contrast. We can tell that because there is contrast here in the aorta. Another little tip for the clinicians amongst us. And we're seeing here that there is hyper-enhancement of this very thickened wall. So it's not just that the wall is thickened, but there is also hyper-enhancement of the mucosa lining the wall. Here we can see on this particular one, we can see that there's actually a focal narrowing upstream bowel dilatation. And so this is a very useful dynamic way of looking at bowel obstruction. This one here shows something slightly different. This is more like rather than the hyperenhancement and an active inflammation of an active Crohn's disease, this is more of a long-standing fibrosing, scarred abnormality. And if you look carefully, what you can see is that there is fistulization. There are about three or four different loops of bowel, which, sorry, that's my phone, which are all meeting at a fistulous point. And so we're able to very beautifully identify fistulae on fetal enteroglysis. Again, we can tell very well these days whether there is activity of the Crohn's disease, because when I was a clinician, we would rely on the Crohn's activity index. These days, we're a lot more sophisticated. We can actually look at the imaging and decide whether what we're seeing is a long-standing inactive Crohn's disease with stenosing disease, or whether there is in fact activity and inflammation. And so the signs of activity on a CT scan are on these images. We see what's called the small bowel feces sign, which is that the small bowel actually takes on the look of large bowel, and so it looks as though it's actually very inflamed. We look for zones of transition between the normal bowel and the abnormal bowel. We look for the target sign that we saw on the previous imaging, and we look for this very classic comb sign, which is where we have inflammatory hypervascularity of the mesentery adjacent to this very, very abnormal looking hyperenhancing loop of small bowel, probably there at the neo-terminal ileum. So not everything in the world is IBD, although that is my particular area of interest. So let's go through a couple of case studies and see some other aspects of plain film imaging. So we've got case study 1 here. This was a 51-year-old man with abdominal pain and had been vomiting for a month. And I think it's not difficult to see that there are multiple loops of small and large bowel here. And here we've got the beautiful coronal recons of the CT scan that was done. This is the other advantage of CT scanning, is that we no longer just can image in the axial plane. We are imaging it in such fine detail that we're able to reconstruct the images in any plane that we wish, so that we can take an area where we're of concern and we can angle it so that we can see exactly what's going on. And this patient had a neuroendocrine tumor with associated small bowel obstruction, which was beautifully demonstrated on this image. This was another case that was fairly recently, a 42-year-old man with a 15-kilogram loss of weight and diarrhea. Again, on the supine film, we're looking at a lot of dilated loops of bowel. It looks as though there is air going right down in the It looks as though there's air going right down into the descending colon, not very much bowel gas seen in the rectum at all. And that's obviously concerning, but it didn't look that bad at that stage. We're looking very carefully here to make sure that there wasn't a loosened liver sign or a football sign, to make sure that there wasn't any evidence of perforation. But in fact, 1 day later on CT scan, what we see is this massive perforation here. This is all air. This is the liver pushed backwards by this large amount of air as a result of a bowel perforation. This was a 22-year-old patient with abdominal pain and anemia, and I'm going to try and run this one through. I hope that this will work. And we have no audience participation here. I'm just talking at the wall, but I'd ask you just to look carefully at this bowel. I'm going to run it one more time. And bring your attention to those very obvious filling defects, there again, in the small bowel. And this is a case of Ascaris roundworm infestation. So it's not just all about inflammatory bowel disease. There's a lot of other infections and infestations which can cause problems and can be visible on plain film too. So we come now to liver imaging. Just a little bit of a nod to MR and to MRE, because it's really a major topic in its own right. But I thought that that it's probably worth introducing the concept here, and perhaps in time we can talk more in depth. So we no longer need to irradiate the patient in order to examine the small bowel. We can do what we call MR enterography, and this has become a very favored technique everywhere where the MR is available. Obviously, MR is not that available in many centers, and so we resort to CT even though we know that there's radiation, which we prefer not to use. But particularly in pediatrics, this is really the go-to investigation. So what do we do? What's the technique? We fast the patient for 4 to 6 hours. We put a hyperosmolar substance, which is mannitol in this case, over 40 minutes. They drink a large volume of this per os, and this draws fluid into the bowel, which allows the bowel to dilate up and shows the mucosal detail very, very well. And we do, I'm not sure that everyone's familiar with the sequencing of T1 and T2 weighted imaging. I'm not going to go into too many details, but fool's guide to MR is that fluid on a T2 weighted image is bright and fluid on a T1 weighted image is black. And we want to image in as many planes as we possibly can. And we require the patient to breath hold very briefly. And we then give gadolinium to do what we do with CT scan, which is to allow the mucosa to enhance. And we have a scoring system which allows us to assess the severity of the condition. I show this slide as just an example that I've taken from our PACS system of what you guys ask us to do. This is not the name of the patient, just in case anyone's concerned. This was the name of one of our consultants here. Jill has obviously known this patient as I probably did over many, many years. And over that time, there's a dizzying amount of images are being produced. And although we think that MR is wonderful, it is time consuming. It does involve a lot of different sequences. And so what you're seeing here, each sequence is acquired at a different time. So if you're wondering why your patient hasn't reappeared back in the clinic after their MRI, it's because they've been on the table for close on 40 minutes probably. So we do imaging without contrast and with contrast in the arterial phase and the portovenous phase. But the number of images is dizzying and would be impossible if we weren't using a PACS system. So here is an example of a T1 weighted image. And you can see that the fluid in the stomach and in the biliary system is black. And unfortunately, I can't see this image here at all. Am I able to reduce that? There we go, that's much better. Contrast has been given to this patient. You can see that there is enhancement here in the vessels and also here in the bladder. So it doesn't take very long for the kidneys to excrete gadolinium, which is the contrast agent that we use. And you will see the bladder appearing white even on a post-contrast, even on a T1 image. So just again, a little bit of basic MR physics. Fluid is black on the T1 image, unless we've given contrast, in which case it appears as hyper-intense or white. Fat is white on both T1 and T2 weighted imaging, except if we do, and here we can see that the fat around the abdominal wall is white, and the intra-abdominal fat is white, and the fatter the patient, the easier it is to see the structures in a sense, because we've got good contrast. But we always use a T1 weighted image when we're going to give gadolinium. What we can do is we can suppress the fat, and this makes the contrast enhancement stand out even better. So here we've got, you can see the difference between those two lower images that are taken in the axial plane. On the left-hand side, we've got the fat, which has not been suppressed. On the right-hand side, we've got the image which has been suppressed. So if we then give intravenous contrast in the form of gadolinium, that the abnormalities shine out. So they stand out and make it much easier to interpret. These, I won't go into too much detail here because I think we're reaching the end of it, but basically these just demonstrate the various coronal images that we take. These are T1 weighted images at various stages after we've given gadolinium. And how will you know if contrast has been given? Here's the clue. The kidneys excrete the contrast in the same way that CT does with iodine, and we notice here that there is enhancement of the kidneys on this fat suppressed image on the right. T2 weighted imaging is fabulous for imaging of the abdomen, because fluid in any form is bright. If you put fluid into the bowel, it shows up the bowel magnificently. And particularly if you suppress all the fat and the rest of the structures that you may not be interested in, you can see the bowel lumen beautifully. So that's an example of a very fast T2 weighted image. This takes a matter of seconds, and we do get this beautiful detail. Similarly, again, on the left-hand side of the screen, we've done a T2 weighted image. Notice that the fluid is all bright. On the right-hand side of the screen, we've done a fat saturated image, which suppressed out the fat. I think I'm going to skip this stage. These are just very beautiful images that you can see. These are taken in axial planes. They're T1 weighted imaging with contrast enhancement, and we can see beautiful detail of the mucosal thickening, almost complete obliteration of the lumen. And here, notice this high signal going towards the abdominal wall. The abdominal wall should appear black on a fat suppressed image because all the fat is being suppressed and made black. And here you can see this large fistulous tract. So here's that big bird's nest of inflammation and infection in the right iliac fossa with a very discrete little focus of fistulization onto the anterior abdominal wall. So the imaging that we get is magnificent. We used to think that we wouldn't be able to image a moving object with MR. That is certainly no longer the case. Perianal disease, beautifully seen on MRI. Again, we use T2 weighted imaging. We suppress the fat so that anything which is bright is going to be fluid or inflammation, and we can see little pockets of abscess collections. We can actually see the fat fistulous tracts. We can tell you whether they are intersphincteric, transsphincteric, extrasphincteric. It's magnificent. Very briefly in the last few minutes, rectal, we wouldn't be in business if we weren't for rectal cancer, and we use MR in the staging of rectal cancer. And all I would bring to your attention is just the importance of good technique. If you feel as clinicians that your images are not clear, it's either because your patient is moving or because the patient hasn't been positioned correctly and the angulation has not been done correctly. So it's terribly important that the imaging is done exactly at right angles to the tumor. And in this example here, what we're seeing is that's an axial and this is a coronal on the right-hand side. in this one here, you can see the difference between those yellow lines and the red lines. The yellow lines the images have been cut correctly, in other words, at right angles to the tumor. And so on the right-hand side of the screen, where we've got this little dotted line, you can see very clearly that there is no plane of, there is a plane of cleavage between the tumor, which is in the rectum, and the anterior structures. And this makes a very big difference. If you had looked at this image in the middle, one might have been tempted to think that there was adjacent infiltration of the anterior structures, which takes the patient into a completely different category, obviously. So positioning is everything. And we use the mesorectal fascia as the cutoff point. Requires preoperative or not. It's called the resection margin, and if there is even 2 millimeters of cleavage plane, the patient usually does not require preoperative radiation. Able to see very well the presence of nodes, and I see that my internet connection's unstable. Please shout if you can't hear me. Cheryl?
Can still hear you, Sally.
Okay, great. I'm going to finish up now because we're at an hour. So I think at some stage in the future, we can talk about MR imaging of the liver as a completely different topic. So I think we'll leave all of that because it really is a separate talk. And I thank you for your attention and take any questions that you might have. And here's Wiley Coyote, who's no longer in 2 dimensions. That is available to us.
I suppose this is the small fistula that you see on the skin, but underneath it, there's a massive amount of information that we still need to dig into. So I think you've given us a nice hors d'oeuvre of what gastroenterology imaging is all about. There are a few questions, and we can quickly see if you can answer them, and I can help you. We just go through them. Firstly,
can I stop sharing my screen, Ernst?
Yes, please
go for it.
Okay.
I just want to remind everybody that Swati has posted a link just for feedback. If you guys can do that afterwards. Akwi has asked a few questions. Some of them, I think, let's start with the more important ones. He asks, if a patient has renal insufficiency or chronic renal disease, is gadolinium safe? And I know that there's new guidelines for the use of iodinated contrast as well for patients with renal insufficiency. So people shouldn't be as scared as they used to be. But if you could maybe just say what you think about
how we
that.
manage it. I try to avoid it. You know, I am old school. I think that MR is such a magnificent tool that you most often can get away with T2 imaging and fat suppression. And while it adds, there's no doubt that it adds to the beauty of it, and particularly for the audience, you know, when you're showing images with contrast, they look beautiful. But if the patient's got severe renal insufficiency, I don't give gadolinium. I just don't. I mean, yes, you can give other agents, you can give the non-linear agents. There's never been a case of sclerosing, nephrogenic sclerosing fibrosis with some of the agents. So you can certainly use those. We don't have them at routinely at our disposal at a state hospital.
Okay.
Yeah.
What's
your take, Ernst?
Well, there's recently been a publication that was shared with from the nephrologist and the radiologist that described the use of iodinated contrast as being safe if the GFR is more than 30 and stable more than 30. So usually what's happened is previously in the old school way of thinking was that the iodinated contrast can cause renal insufficiency and is nephrotoxic. So there's a movement away from that. So you mustn't deny your patient imaging with contrast, which adds to the diagnosis if they have slightly impaired renal function. So GFR of 30 is published in the American Contrast Manual, which you can look up on the internet. And I agree with Sally, you can get a lot of information, but if you need contrast and you need to speak to the radiologist, the benefit, if the benefit outweighs the risk, then you can do it. Then you must do it.
I would accept that. Certainly with CT. Certainly with CT.
Yes.
And MR, I think we've just got other sequences that we can use. Yeah.
Okay. And then Enoch asked, when do you use low-dose CT scan? And maybe, I suppose, when would you use MRI? And I suppose that would be a population-based question, like young patients versus older patients.
Agreed. Always use MR for in the pediatric population. You'd never, ever find our pediatric radiologists using CT. Often it is a question of accessibility on the scanner. You know, we have a 6 to 8 month waiting list for non-urgent scans, so on MR. Whereas CT, you know, the patient's on and off the table within 20 minutes. So it's, yeah, that's often the criterion.
One of the earlier questions was just, how do you differentiate on the plain film between an obstruction and a perforation? But I think the question is that if there is obstruction, it can turn into a perforation, which you will then see free air.
Correct.
I think that sort of answered itself. Akwi also asked, how do you differentiate between portal vein air and biliary air?
Yes, so that was the point that I was making on those two diagrams, where it's central, it does not go out to the periphery when it's biliary.
Yes.
You don't always see the main bile duct, but it does not go out to the periphery, whereas with the portal gas, it's usually finer, more thready, and goes out to the periphery.
Yeah, I always remember that the portal vein, the blood gets pumped into the liver, so that air will go all the way to the periphery of the liver, and biliary air is trying to get out of the liver, so it will be more central and towards the center of the liver and not the periphery. But yes, that's answered. And I think another question was, what is a transition point, and how does ileus have a transition point?
So ileus should not have a transition point. Otherwise it's not. But transition points are great when you see them, but you often don't. Even on CT, you know, you could spend quite long periods of time looking for the transition point. You know it's there because there's a bit of bowel that's dilated, and then there's a bit of bowel more distally that's not dilated. So in a sense, there has to be a transition point, but sometimes it's very difficult to appreciate. When it's easy on CT, I suppose plain film, very difficult on plain film. See, it's a CT diagnosis.
I suppose if there's a transition point on plain film, you'll have loss of air in the bowel distal to the transition point.
Yeah, so like so like a sigmoid cecal volvulus, you know, you're not going to see air in the large bowel. Yeah, that pancreatitis, when you get the sort of the inflammatory ileus adjacent. That would be a case where you would have an ileus adjacent to a pancreatitis.
Yes.
So there would be a transition point there, wouldn't there?
A question from me is, do you have any experience looking at pneumoperitoneums with ultrasound? Because we can see...
Me personally, no.
Because the reason why I ask is also, like Chris said, we're focusing on the patient of care ultrasound. And I know that the trauma surgeons can see pneumothoraces with the high frequency linear probes in the chest. Yes. And I've personally also had, well, just anecdotal experience of seeing a lot of air in the abdomen when you are actually expecting to see solid organs or bowel, and there's just a air artifact. And if you have the pre-test clinical probability, and that's what the clinicians always have more than the radiologist, and I also hear the histopathologists complain about this, that we never get a history. But the clinicians at least know, you know, if the patient's been stabbed, that there's a high chance of a perforation. So if they put the sonar probe on and there's a massive air artifact, then it's highly likely that the patient has pneumoperitoneum.
Yeah.
I think there's one last question. I don't know, we have maybe no time. It's just about patients who are allergic to contrast. Do you maybe want to say something about that?
Yeah. Again, you know, I'm old school conservative. If the patient says to me, looks me in the eye and says, I had a terrible urticaria reaction last time you gave me contrast, I'm not going to give it without doing prep. So we have a very clear protocol on what to do. The combination of steroids and antihistamines. And if the patient needs contrast on a CT scan and it can wait, we'd certainly do that.
I just want to say that, add to that, that shellfish is not an indicator of iodine allergy. So it's something that was taught a long time ago. The clinicians always ask it. We see it always written on forms, but there's no correlation between shellfish allergy and CT contrast allergy.
Iodinated contrast.
Absolutely. So,
you know, one must never speak too soon. But when I started radiology and we were doing IVPs, we would have reactions every day. Every day we have a reaction.
Sure. Is that the high is that the high osmolar contrast media? Okay.
Thankfully, things have changed.
I think that's pretty much.
One last question, Ernst, just about pneumatosis intestinalis and COVID.
We haven't seen it. So if we can maybe hear if Sally has seen it. We imaged a lot of patients. Our population here is a lot of oncology patients, transplant patients. Some of the oncology drugs can cause pneumatosis, which is then incidental to the patient having COVID. But we have not seen pneumatosis intestinalis from COVID. I think it could happen after the patient is on a ventilator and he is in ICU as a complication of prolonged intensive care. But I don't think there's a direct mechanism. But I mean, you would know, Chris, if there's a mechanism. I know COVID has receptors in the gut. Sally, did you have any experience with it?
No, I don't have any experience of the pneumatosis, but yeah, certainly we know that the gut is affected by COVID. Chris, any experience?
No, not much at all.
I know we overcall, the clinicians tell us that we overcall pneumatosis. You know, I think that everyone is so terrified of seeing air in the bowel wall that we tend to overcall it. And I think patients get taken to the OR for what is actually not pneumatosis.
Yeah. One of the participants just mentioned bowel gangrene in COVID. I think that could also be with the
arterial. Oh yeah.
Vasculitis.
Yeah.
Oh yeah. No. Sorry. As a vascular complication, absolutely. Yes. We've seen a lot of that. Yeah.
I just want to, lastly, before we go, say that there is a very important part of radiology is to do the correct test for the correct indication. And there's a wonderful tool on the internet. It's called the American College of Radiology Appropriateness Criteria Guidelines. You can Google it. It has an amazing evidence-based approach to a lot of variable clinical situations, and it will tell you what test is the best test to do for a certain clinical situation that you have. That's usually if the radiologist can also help you with that if you phone them. But if you don't have that and you just need to know what is the best test to do for this liver cyst, then you can look it up there. And that's all from me. Thank you, Sally.
Oh, thank you very much. We've got a violent storm in Johannesburg, so
I believe so.
Get on so you can hear the internet.
We have a violent wind in Cape Town.
Thank you, Sally. True masterclass, and I hope we'll see you more often, which I'm sure we will. And Ernst, thank you for the lively chat.
Thank you.
Hearing so effortlessly. So it remains for me to thank ECHO New Mexico and also the ECHO India team for their valuable support. Please, there is a feedback link which we'd ask you to feedback to us. It helps us strengthen our sessions. The recordings are available on the Gastro Foundation website. Thanks to Cheryl and Karen for their technical and whole support. And thanks to our sponsors. And next week, we introduce the second of our new subspecialties this year, which is going to be gecko pediatrics. So we're going to devote sessions entirely to pediatric GI hepatology. So I encourage you all to attend. And then we're having another radiology session shortly thereafter. And I'm hoping we'll have a guest speaker introduce POCUS, which, will, as I said, will be a very important priority of the foundation in its teaching this year. So thank you all very much. Good afternoon. Stay safe. And thank you for joining us. Ernst. Oh, goodbye.
Yeah, no. Sorry, I was going to. It might have been the internet connection, so there was a pause, but it was actually away.
Okay, thank you. Thank you, Sally. Thank you, everyone, for joining. Goodbye.
Bye
Ciao.
now.